Welcome to an impromptu conversation with Laura and Dave. I'm Dave. I'm a dentist anesthesiologist,
All right, hi. I'm Laura. I'm a family medicine physician.
and we want to talk about. Well, I'm going to talk to you,
Yes.
but we want to talk about some important issues in medicine because
Hmm.
dentistry is part of medicine. I've heard that the mouth is part of the body.
I've heard that.
Yes.
They
Yeah.
strangely got separated.
Yeah. That's a historical problem.
Uh-huh.
Um, it was today. I had an interesting experience. We had our accreditation site visit for the general practice residency. You're well familiar.
Congratulations.
I know
Yes.
you know many of the people involved, and it was generally positive.
That's great.
We talked a little bit about the history of the GPR and how it's developed over time, and we've had our bumps and lumps, and sometimes people haven't fit in, and we've gradually gotten to a place where we've got a solid director. I think we get along almost all the time with the different faculty, and I believe we're generally supportive not only of the faculty but the residents. Um, I don't know if any of your experiences in medicine are like that.
Yeah, I mean, it varies so much between different kinds of residencies. In
Mhm.
family medicine, I would say, in general, you tend to find a pretty supportive team and faculty. Um,
I like the crew at OHSU.
yeah,
I think they're
yeah,
good folks.
yeah, absolutely. Yeah. My own residency experience, yes, we had phenomenal faculty. It's
Mhm.
such an intense time. But I really had a lot of connection with my colleagues, with my fellow residents. And that was really meaningful to
You
have
know,
that community.
one of the things I wonder about, I know there was a big change in medicine that kind of started in 2012. They changed the MCAT in 2015. They've
Mm-hmm.
tried to change residency training programs
Mm-hmm.
where they were trying to shift to greater emphasis on empathy and critical thinking.
Mm-hmm.
Do you see that playing out?
Um, it's, let's see, those students would be just getting through residency or would be a little bit past residency. Some may still be in fellowship. So,
Hmm. Just popping out, baby doctors.
right, exactly. So, certainly that cohort wouldn't be influencing, wouldn't be in established practicing physicians very much and would be junior physicians. So, I wouldn't expect that cohort to be having much of an influence in practice. Now, would the faculty who are meeting this new cohort and creating curriculum around new goals and bringing empathy into practice? I do. I don't have a lot to compare it with.
Hmm.
I am currently volunteer faculty at WSU, and I do like a
Washington
lot.
State University.
Yeah, yeah.
Yeah.
I'm really impressed with a lot of what I hear and where the curriculum's going.
Hmm.
But the students are also with community physicians, so they're still in the same soup, in the same stew. Um,
Hmm.
that um, is trained before this emphasis, and then you have all the changes from the pandemic and the lack of time and burnout, and so there's a lot of challenges for physicians in training
So
with who they're modeling.
how's
Who's
this
modeling them?
playing out in practice even today? Are people moving towards this model of greater empathy?
Yes and no. I think in a clinic practice, there's so many pressures to see patients, to get throughput, to be rapid, be efficient, that um, it adds to the challenge. Now, to be perceptive, to be reflective, to be self-aware and self-compassionate, that doesn't take more time. Um, and there's certainly a perception that listening um, and being empathetic is going to extend your visit, um, which isn't necessarily true.
I certainly see plenty of evidence in the literature that empathy, well, what I've read, and you know I've read that literature a lot, is that essentially if you have a better connection with a patient, you get a better outcome for free.
Mm-hmm. Oh,
I
yeah,
mean,
100%.
maybe it takes you 90 seconds or 2 minutes, but I mean, essentially you're getting a better. In fact, I've even read you can maybe you're a little off on the diagnosis, or maybe not the perfect med, but the patients do better because of the connection.
Oh, yeah, 100%. They trust the diagnosis. They are more adherent with the medication. There's great evidence, great studies on how a patient who trusts a physician is more likely to stick with the medication regimen. But 2 minutes, if you have a 7-minute visit, is a
It's a big chunk of
big
time.
chunk of the visit. So I was just listening to an article from 2023 in the New York Times on moral injury and physicians. So yes, it helps, but there's such powerful forces that are making medicine harder. Making harder maybe isn't the right word, but are sapping the energy of physicians that are working against creating the space for that connection.
So in other words, we know how to do it right, but we're not doing it because it costs too much.
Because if I, as a family physician, do an excellent job in caring for my patients, they're not going to need the heart surgery and the knee surgery. And we don't have a system now that captures the value of what it is I'm doing. There's movement towards that in value-based care, but how do you capture the value of a patient not having heart surgery?
Well, what about the relationships between physicians? How's that? Is that making a move?
That's I don't know how much that's changing yet. In that the culture of medicine is something that's it's really a powerful influence on how we define ourselves, how we practice, and it's transmitted in the ways that we interact in what's considered normative behavior. And but I don't know how many physicians, how self-aware they are of what they're taking on. I think many are very aware of the culture of medicine, but we enact this without necessarily questioning the values that we're absorbing. I remember when I was in third year of medical school, and I was at OHSU on a rotation on the wards, and I was in the elevator, and there were two women who got on the elevator, and they were talking about how they had just worked a 12-hour shift. And I had worked 24 or 30.
But I did an anesthesia residency. Believe me, I get it.
So in that moment, though, I listened to them, and I felt so judgmental of them. We got the thumbs up sign. Why are they complaining about a 12-hour shift? And then I realized that's how it happens. That's me becoming accultured.
You're being judgy.
That's me taking on the physician culture of we sacrifice so much more, you have no right to complain.
So I've read a lot about how, well, I don't, if you've looked at some of the evidence on empathy from Jefferson Medical College.
Well, back to that point, it was a moment of self-awareness that I don't know how much is occurring in that moment of training. So that ability to reflect and say, oh, that attitude, I'm not sure that that's coming from me. That's in the stew that I'm being cooked in here.
So it was making think of the modeling.
Yeah.
That there are many journal articles from Jefferson Medical College from their instrument on empathy, showing that the most empathetic is when you start medical school
Yeah.
or start dental school,
Mhm.
and it decreases,
Mhm.
and then you go into residency and it decreases more,
Mhm.
and the evidence seems to point towards modeling of your mentors.
Yes. Yeah. And that's where people who've been in medicine for many years, who aren't faculty, who aren't designing new curriculum, who aren't intensely focused on interrogating the values of the physician culture, of medical culture, have not, may not have moved away from how they were trained in the 70s or 80s.
Okay, well, I think we've posited the problem.
Mm-hmm.
What do we do about this, Laura?
So, one of the things I'm really curious about, and I think is an area for thought, for study, is on the one hand, you have this tribal Stone Age brain that we're walking around with. And part of that is an intense need to belong. If in 10,000 years ago, if you were shunned from the tribe, you did not survive. And I was reading about this, and the maladaptive coping mechanisms we all use at times, like our negative bias and jumping to conclusions and mind reading. The brain evolved not to make you happy, but to make you survive.
Right.
Yeah, yeah.
So
yeah.
I was reading some, maybe it's a little tangential,
Mm-hmm.
but it was about veretical perception, perceiving truth.
Mm-hmm.
And there have been a series of studies done in the psychology literature
Mm-hmm.
where they talk about how even highly educated people, they can be told something that perhaps is a lie on one day, and then they're with a group of people, they're all told that lie, and they kind of revel in it a little bit, and then the next day they're told it's not true, but they don't let go of it.
Right.
And they still tend to hang on to it.
Mm-hmm.
And what the authors have said in several of these studies is because of this deeply instinctive need to belong.
Yeah, absolutely.
And hey, look at our politics today.
Right, right.
You know?
Yeah, to
Yeah.
change your beliefs would put you in the out group.
Exactly.
And the
if
cost of changing.
well, yeah. Well, if you brought the example of ancient societies, if you're an outsider, you die.
Yeah, exactly. So the pain of shunning, of being an outcast, is as powerful as physical pain. It's felt in the same neurons. So there's this powerful drive to connect, to belong, and yet when I talk to physicians about what do you want from work, it's what do you want from employers? And granted, it may not be the right question, but what I hear is I want the tools to do my job.
Mm-hmm.
I want a full exam room. I want the EMR. I want patients to be arriving on time. I see them. I have the tools. They leave. Great. I don't hear I want to feel like I belong. I have never heard that. Now, I sometimes hear I want to be valued. The fact that we are saying that I want the tools to do my job as a need, the fact that we're saying that out loud, I mean, that's pretty surprising in and of itself that that's not a given. But if you're articulating what you want from work, that's the baseline. But I don't tend to hear much more than that when I ask. Now, maybe a more accurate question would be how you want to be treated or how you want to feel. So that may be part of the issue, but I don't see written about, I don't see a dialogue happening around a sense of belonging and what that means in a work setting.
So is this some way related to what you have referred to as the hidden curriculum of has this been modeled, this need for being a rugged individualist,
Oh yeah,
or just
100%.
not connected, or isolating your feelings from other
Oh
people.
yeah, definitely. So the idea of professionalism at work is very much staying neutral in your composure.
Hmm.
And that's one of the biggest influences in our medical culture is William Osler, who I have a lot of respect for. He
Hmm.
created the modern medical residency, but he talked about how you have to practice with your head and your heart in equal measure. And in his Equanimitas talk on maintaining equanimity in front of the patient, that was a graduation speech in the 1880s, I think, he talked about not displaying your own fear so as not to frighten the patient.
Hmm.
And this was a time when there were few cures,
Hmm.
there was tremendous suffering,
Hmm.
um, and you didn't want to add to the patient's suffering by showing your fear for the patient. But that's come to be interpreted as not showing emotion. Um, and it's also in the concept of professionalism, not just in medicine, a sense of uh, remaining neutral with emotions, definitely regulating your emotions is a part of professionalism, but it's tends to be impersonal, is what's valued, which granted, if you are at work from 9 to 5 in something that is fairly low stakes, it's a very different experience than if most of your waking hours are at work and it's a
Hmm.
really high stakes occupation.
But that kind of went off what medicine historically did, though. Like Hippocrates,
Mm-hmm.
Galen, Maimonides, Hildegard von Bingen,
Mm-hmm.
didn't they talk about tuning into patients' feelings?
Yeah, and there's a lot of that's certainly been an expressed value, but that was before Osler and modern medicine.
So he convinced everybody to go.
Yeah,
Well,
yeah.
it maybe unintentionally or intentionally, they went a very different direction.
So yeah, you pay attention to the patient's feelings, but you don't
Don't pay
express
attention to
your
yours.
own.
Mm.
Yeah, exactly. And
Or,
it's this remaining neutral.
or don't let your feelings show for the patient.
Right, exactly.
Mm.
So there's a lot of stigma around not looking competent, around displaying your own mental health concerns. In that, is that going to affect patient care? Um, and there's so there's that part of the culture of valuing independence,
Mm-hmm.
of the nobility of the profession combined with the long hours, definitely leads to um, I wouldn't say an emphasis on self-sacrifice, but it's you can see how that becomes really prominent in the culture when when this work is inherently noble, the hours are long, self-sacrifice is a really prominent value. So then for the physician to say this is what I need has not been expressed.
So that's contradictory to those
Yeah.
values.
Hmm.
And yet, I would think that would just amp stress and amp
Absolutely.
dissatisfaction. And
Hmm.
in
There's
turn, maybe patient outcomes are
oh
not so
yeah.
good.
So there's great data that shows when physicians don't feel valued,
Hmm.
they don't stay. And when they don't feel a sense of belonging, they don't stay. So we know what happens when it's not there,
Hmm.
but I don't hear physicians articulating the need for this to be there. It's just when it's not there, people don't stay.
So these physicians feel guilty for having these feelings.
I believe so, in that it's because there's not a conversation about this, each individual physician may be thinking this is theirs alone.
Well, I certainly have met plenty of people that are stressed.
Mm-hmm. Mm-hmm.
So what? I know you've thought about this a lot.
Mm-hmm.
what do we do about this?
Yeah.
How do we address this?
Yeah.
How do we get to a better place?
So we're not going to change the system,
Mm-hmm.
and we are resilient.
Mm-hmm.
So this isn't about building resilience.
Mm-hmm.
There are work situations where it's just not going to work to stay, and that's I want to lead with that this isn't going to make an intolerable situation tolerable. But what mindfulness is, what self-compassion and self-transcendence is just that thought, other people feel this. That alone can be really powerful. When you think about the self-compassion scale, people who are not very self-compassionate may tend to think, when I fail, I'm alone in my failure. This is unique to me. Other people haven't experienced this. Well, we don't share it when we do, so how would you know?
You know, it does remind me of the traumas in the ACE studies, and that to counter that, if people can get through their traumas, they have to have resilience, and of that, 9 parts of that are support of other people.
Yeah,
So that seems to speak to what you're suggesting.
And so in the culture, what are you seeing in dental culture about the need to be individual, the need to maintain composure at all costs, to
I don't think it's a
judicious
lot
about your feelings?
different, but dentists are still more solo than physicians are. They still have more private practices versus group practices, although that seems to be changing. I do hear a lot more dissatisfaction when people are dealing in corporate structures.
Yeah.
And it seems like the corporation has different values than their personal needs. So I've certainly heard about that, but I also hear about people that get frustrated when they don't know what to do and they're responsible for everything. And that's one of the motivations for being part of a group.
Exactly. So how do we take this into the workplace is what I'm wondering. How do we take the values of self-compassion, of self-transcendence, of mindfulness into the relationships with each other? Because we've talked a lot about physician-patient relationships, but how do we do this with each other? Knowing that we're not going to change other people. The Buddha said you can either cover the world with leather or you can put on shoes. So take your pick.
Okay. Okay. Well, I mean, and that kind of leads me to thinking that maybe this model is no different than working with patients, is that it's the same thing, that you've got to be curious about your colleagues and pay attention and then be empathetic. Think about, okay, what's going on in their heads, and see, does that resonate with you? And if you want to help each other, you're going to have compassion and do something.
One key difference is when you're lower in the hierarchy, when other people have a say over your experience and over your work environment that you may not have. And recognizing that the tools are still effective there. Now, again, it just may not be a tolerable situation, but when you think about somebody you're struggling with at work who may be in a position of authority, what was their training like? What is that backstory, which you don't know, but you can imagine? What values did they probably absorb? And just stepping back, looking at that and thinking that this isn't personal, that it's not your failing. It's like being the fish that sees the water you're in.
I would imagine that they're suffering as well, but they just don't. They bury it.
Yeah, and that's a culture, and so it may come out in inappropriate ways. I mean, one way to regulate your emotions is to blame other people.
Right.
Not an effective strategy, but that happens.
Or they find other coping mechanisms like bad habits, too much food.
Mm-hmm. Yeah.
I mean, I found it's not all that unusual to find physicians that are overweight and not paying attention to their own health, and they die of a heart attack.
If your boss is overeating, not going to affect you. But if your boss is blaming other people for as a way to regulate their emotions, that will affect you.
Yeah.
And having the ability to look at that situation, to have the self-awareness and the reflection to say, this is the dynamic. I don't own that piece.
Yeah, it's odd.
Really
This is
challenging.
We're supposed to be in a caring profession. Why don't we care about each other?
Yeah, and that's the question, and how, if you're one person in the matrix and you change, well, the matrix has to change a little bit, and that's really uncomfortable.
So we're working within these structures. What can we do, at least to help ourselves get through it?
Yeah. So it's that being aware of your own self-talk. When you have an adverse event at work, is it a bad outcome? Or you've had a difficult interaction, what are you telling yourself? What are you assuming other people are thinking? That's that mind reading, which if you're trying to escape a bear in the woods, you're trying to not interact with somebody dangerous, you're going to anticipate what they might be thinking about you. But in this situation, to be assuming that other people have these thoughts about you, these judgments about you, which may be entirely fiction.
But you'll play those in your head.
Yeah, so it's not about not having those thoughts. It's not about not having the self-talk, but it's about having one step back to say, oh, there's that thought again. Oh, look at that. There's that self-judgment. Okay, that's okay. But it's, you don't have to go with it. And recognizing in those relationships at work, what are other forces that could be at work here, like the water to the fish, and recognizing that you're all in this culture and it's influencing everybody.
So rationally, a certain amount of self-talk, if you screw up, I guess is constructive. But the repetitive self-talk is destructive.
Yeah, so the self-talk of, okay, this didn't go as I wanted. I want it to be better next time. This is how I'm going to achieve that. But I'm the only one who's screwed up. I'm being singled out.
I'm unworthy. I'm incompetent.
Right.
Whatever your self-talk happens to be.
Right. And, you don't know what has happened with other people and what kind of private conversations they've had with staff and with leadership. And hopefully you don't know if you don't want your stuff to be known by everybody. You got to remember there's probably stuff happening that you don't know about, and to take that wider view.
So what message should we leave people with?
Well, act where you can. So where you are in a leadership position, where you are managing a team, taking the good habits with you of being empathetic and using those skills that we've talked about with patients when you're working with a team, of not assuming, of being present and seeing another person. To be seen is so powerful. And that you're not always called upon to fix something, but just to be present, to give positive feedback. 4-to-1 is one ratio that's suggested.
There's an algorithm for it.
Yeah, exactly. Because we tend to, negative bias, only give feedback when we need to correct. Not here, not there, not here, not there. But it's really nice to know when you're on the right path instead of just hearing when you're not.
Are you familiar with the power over power with model?
You've talked about it. You can say a little more here.
Yeah, it's they're oftentimes, especially when people are not really trained in leadership, as some healthcare providers are not, they will drift into a power over where they just tell people what to do and they expect them to comply. Versus, I think if you're a good leader, you're trying to bring other people up.
Exactly.
You're trying to help guide them through their errors or their hard times. You're trying to, whenever you can, share what's going on. If there's a task, can you share it? I mean, in an emergency, you tell people what to do.
Right.
Of course you do.
And a code.
Yeah. If there's a code, don't
Very
mess
directive.
around. But if you're worried about what color to paint the walls, you can delegate it out. And there's all various levels of that. I think that's one of the most important things we need to do too, is to teach healthcare providers good models of leadership, so that they're working well with their colleagues and bringing other people in and bringing them up, rather than telling them back off.
Right.
Stay in your lane.
Right. And with your staff, making sure that you're demonstrating all the qualities that you want your staff to have, and that you're creating a cohesive team there.
I think that's a good message to end with. Thank you.
All right. Thank you.
Thanks, Laura. Good to see you.
You too, Dave.